Maggie, thank you very much for this kind invitation. I must say that in the United States, when we visit other units and we look at the level of productivity, we have emotions either of envy or respect. Respect for what's been accomplished, but envy for opportunities. And I must say that have been filled with envy at every minute that I've been here since arriving so late last night about the most remarkable opportunities in Qatar that I really had little knowledge about before this kind of invitation. So I'm looking forward to my experience in your environment, perhaps much more than you mine. So anyway, we're going to talk about INTERMACS for the next 20 minutes or so. And sorry, I'll use this maybe. So many years ago, in 1991, there was a report from the Institute of Medicine in the United States after the completion of a formal report of the Total Artificial Heart Project. And this was involving a number of people at the National Institutes of Health in reflecting, scientists reflecting about what to do about mechanical support, which was really not a reality at the time. And they noted several things that I've highlighted because of the patient's total dependence on these devices and the fact that they would need to be followed throughout their lives. They thought it was very important to maintain a formal database, a registry for these patients. And that this should be really part of routine practice. So that was in 1991. And it wasn't until a number of years later that it became increasingly apparent as destination or so-called permanent therapy was becoming available in the United States that reports from single institutions just could not generate enough scientifically valid information to affect reliably practice and practice patterns in the United States, nor could they reliably provide the data which would facilitate the introduction of new devices. So the NHLBI put forth a request for proposals in 2005 to set up a national database for mechanical support in the United States, and we were fortunate enough to receive that award at University of Alabama, and this became INTERMACS, which is really an interagency mechanically assisted circulatory support database. Really that means is that this was an experiment, truly an experiment between NHLBI, FDA, the Federal Drug Administration, Centers for Medicaid and Medicare Services, the payment or reimbursement entity for many patients in the United States, and clinicians, scientists, and other stakeholders. And so it began as a partnership in a way that had never really been accomplished in the United States involving the NHLBI. In which industry also played a role, as well as the FDA and CMS. There were specific goals articulated, and I think these have some relevance to why I'm hoping that you all may be interested in this pursuit. The refinement of patient selection is a very important goal, identifying risk factors for successes and failures of this therapy. Develop best practice guidelines, guide clinical application of next generation advices, and guide improvements in technology and facilitate devices working their way through the regulatory process. So this is a compilation of the experience within INTERMACS, and in the blue line, you can see the hospitals that have been recruited in the United States. There are now over 130 hospitals. And the red indicates the accumulation of patients, and now it's expected in July of this year that we will reach 10,000 patients entered into this database, which is, I think, quite an unusual accomplishment just in terms of accruing patients because of the rather limited at any given hospital application of this therapy. I want to show you here the platform, the environment, the landscape of mechanical support and how it's changed so dramatically in the United States over the past 6 years. When INTERMACS started, there was no continuous flow pump which had been FDA approved. And so at that point, they were essentially all pulsatile intracorporeal pumps. But very rapidly, with the introduction of the HeartMate 2 device, and eventually later for permanent use of this device, continuous flow pumps, at least currently, absolutely dominate the field, and greater than 99% of pumps implanted in the United States now are continuous flow pumps. So what I'm going to do for most of this particular session is I'm going to talk about survival and what we have learned about predictors of survival, the limitations on survival, and so forth from this large database. So at first pass, we can see that now this is the overall experience since 2006, and we're looking now at left ventricular assist devices of any type, just simple actuarial survival. You can see immediately for those patients who require biventricular support that the early mortality is higher. That's not new information. And then there are a relatively small number of total artificial hearts implanted in the United States, and their survival has been intermediate. If we look now at further stratification and focus on continuous flow ventricular assist devices, the upper curve, and we can see that if you look at all devices now censoring at the time of transplantation or explant, that a very important number to remember is that at 24 months, 2 years, the survival currently, at least actuarially, is 70%, which quite honestly 5 years ago was thought to be a really unachievable barrier based on the early experience with the so-called HeartMate 1 XVE ventricular assist device used for chronic implantation. So let's take this actuarial curve then. This is the devices that we care about currently, continuous flow pumps. Again, the 1 and 2 year survival. The red indicates the hazard function or the instantaneous risk of death over time. And based on this, we have done a multivariable analysis in the hazard function domain to look at predictive risk factors. And we repeat this every year. And in this case, there are an array of risk factors, which may not be a great surprise to you, but they relate to things like, They relate to things like certain demographics, clinical status, non-cardiac systems, right ventricle, and surgical complexity. So we're going to look at some of these in a little more detail to give you some more insight into really what you might expect with mechanical support today. So destination therapy. Now that means in the United States, the intent for permanent implantation of the device. You can see that it has its effect in the constant phase, a moderate increase in risk. And here is a stratified actuarial, not risk adjusted, but indicating the raw data to suggest the difference between destination and bridge to transplant therapy. Now, there are many reasons for these small differences. One is you don't have the opportunity to explant the device when the patient has a complication, and therefore just transplant him or her. But there are other reasons that indicate that across the board, destination therapy patients have slightly less good survival than bridge to transplant patients. Now, destination therapy is becoming an increasingly important component of this patient set. This is by year, and just note, for example, that by 2012, approaching 50% of the patients implanted in the United States receive devices with the intent of long-term therapy. Older age, clearly a risk factor. some of us in the audience get more and more interested in this as risk factors the days pass. So here's again stratified by age. So under 50, the red is 50 to 60, and the green is greater than 65 years of age. Not a great difference, but across time, it is a difference. And what is of interest that you can see, if there were a hazard function here projected at the same time, you could see it's an early phase, that after about the first 6 months, the survival is parallel between the groups. And of interest, some have thought, well, okay, 65 is fine, but what about those who are getting into the 70s? It's interesting that at least for the, it's important to understand this statement, at least for the patients selected by physicians, doesn't mean any 70 or 75-year-old, those selected for implantation appear to do as well over 70 than patients age 65 to 70. So there doesn't seem to be anything magical about the age of 70 chronologically in itself. Again, this is an increasing proportion of patients in the INTERMACS experience. Now, in 2012, 50% of implanted patients are over 60 years of age. So let's discuss the clinical status of them. Of these stage D patients, how sick are they really? And we have determinations for INTERMACS of levels 1 through 7, and you can see that the highest level is a risk factor. So early on in the process of INTERMACS, it was clear that New York Heart Association Class 4 was not really discriminating enough, and so a number of very thoughtful cardiologists, in particular Lynn Warner Stevenson, was driving this differentiation. So these are levels of New York Heart Association Class 4 that have now come to be known as INTERMACS levels, 1 through 6, and then 7, which is so-called Class 3B, if you believe in such a thing. And what's important is that classes 1, 2, and 3 are those patients who are either inotropic dependent or rapidly deteriorating, class 1 being in shock. So if we look at the difference in survival with those various entities, we notice that the class 1, those in shock, have a worse survival. And I will say that based on earlier analyses in INTERMACS, this curve was much more profound in its early risk of death, and it was down to at least 70%. But it's interesting how I think correct me if I'm wrong, the Hindenburg principle, something close to that anyway, the fact that if you observe a phenomenon by the act of observing it, you begin to alter it. And this is perhaps INTERMACS' version of that, because we looked at all these level 1 patients so often that it began to change clinical practice, surprisingly enough. And people thought, well, geez, these patients are dying when they're in shock. Maybe we shouldn't put in a durable device at that time. And so, lo and behold, the results of the patients they did put it in got a little better as they began to perhaps be a little more discriminating in their selection. So our ability to show this as a risk factor is now beginning to disappear. So it's very important to remember past history when you're doing these analyses. So again, a survival benefit if you're not quite as ill. Again, my statement is documented in this chart, 29% before 2010, and now only 15% of patients are implanted in cardiogenic shock. Although older patients, if you look across the board in stratified actuarial terms, do almost as good. Don't be deceived, because elder patients are more fragile and they don't have the reserves. And this is illustrated here in this interaction between age and INTERMACS level, and you can see that the more pronounced increase in the probability of death within 1 year for INTERMACS levels 1 and 2. So the older you get, the more cautious you need to be in general about implanting devices in patients who are extremely ill or dying. Let's look at another renal subsystem, the so-called cardiorenal syndrome. It does seem to have an impact early, and for reasons which are a little bit mysterious, creatinine, or as reflected by the glomerular filtration rate, shows its impact in the more constant phase. BUN or dialysis indicate an acute event of renal failure before implantation. But if we look at, again, some interesting stratified actuarial curves, if you are having severe cardiorenal syndrome, either dialysis or estimated GFR less than 30 mLs per minute, there is an important impact on early mortality after implantation. And one of the things that we've noted in a recent analysis is that there has been some ongoing debate about cardiorenal syndrome as to whether or not the implantation of a mechanical device really reverses some component of cardiorenal syndrome, or whether it's temporary and it is somewhat inexorable and immutable phenomena, which is going to continue to get worse after the device implant, at least with a continuous flow device. We have a little evidence here which contradicts that statement, and looking out to at least 2 years, we have now data that if you have these patients who, whether it's severe on dialysis, moderate or mild cardiorenal syndrome, when they get the device, there's a bump in their GFR, and then a slight decrease, but note it is quite stable, remains stable in this large cohort of patients at whatever level it is, out to about 2 years. So I think there's some reason for optimism that despite having cardiorenal syndrome, that if we can impact, particularly early or even in its moderate stages, we can at least preserve kidney function to some degree in the longer term after mechanical circulatory support. And this has very important implications in the selection of patients. Right ventricular failure, obviously that's a very major risk factor and is going to be one of the areas of intense focus in the years to come with mechanical support. For those that have severe enough right ventricular failure to require biventricular assistance, as I showed earlier, they have a very major fall off in mortality or in survival, with 30% mortality within the first few months. Those who have moderate, you might define that by a higher right atrial pressure or elevated bilirubin or ascites, and then those with low or no right ventricular dysfunction have the best survival, and again, not surprising. And then just another little piece of information that's important to realize as one is planning these operations. If you have a history of previous cardiac operations or important concomitant cardiac surgery, it does increase the risk a bit. And once again, in the elderly, they have a little bit less tolerance for more complicated operations and reoperations. So let's look briefly, just for a moment, to give you a sense of the causes of death in these patients. And these are all the causes of death that we have codified from INTERMACS. And just a couple of notes that might be of interest. Note that in the era before 2010, infection was the major cause of death, and this is just any time after implant. This related in large part to the number of bulky XVE, larger ventricular assist devices, and their tendency to become infected. 2010 to 11, it doesn't indicate a numerical difference compared to earlier, but now neurologic dysfunction is starting to become a major cause of death. And this is very important because, of course, in a talk I'm going to talk about tomorrow, this obviously has a major impact on quality of life. And then 2012, now we're beginning to get those patients who are dying of multi-system failure as the major cause cited in mortality. So this is now an advertisement. So this is a disclaimer, but I thought I would just show you that industry is at least finding INTERMACS to be of some value. So in a recent talk in Washington, Hardware was noting their relationship, not financial I might emphasize, but just their benefits of their relationships with INTERMACS and using them. For example, they were the first company to use INTERMACS as a control group for their pivotal trial in the Bridge to Transplant group. We are, of course, doing their post-approval studies, and they were very complimentary about what we've done for industry. We do have a number of publications. I'm not sure we're doing as well as your scientific foundation in Qatar, but there are a number of publications that have been generated over the past few years, and many co-authors from many institutions have been actively involved, and that's one of the things that we're trying to push for. So I want to just take the last couple of minutes in this session and tell you about the opportunity, what I believe, for Qatar and your interest in mechanical support. So I've long thought that there were many, many more important things in the world than just what was going on in the United States. And so actually with the inception of INTERMACS, I began to think, how could we have a more global effort to collect high quality data, not just collecting data, that's easy, but high quality data in mechanical support. Certainly the ISHLT had a track record of collecting at least reasonable data in transplantation, but had a lot of difficulties for some political reasons in getting people to want to contribute data on devices. So we developed an opportunity and had many discussions, and actually then put forth a formal proposal to the board of directors in 2012 for an ISHLT MAX, if you will, IMAX database, which would so I apologize. I may have to get Dr. Yaqub for the rest of this to handle the movement of the slides back and forth if I can't do a better job. So what I want to emphasize is the scientific investigations. In my mind, there's no reason to have a database and go to all the work to put in patient after patient unless you can benefit by getting access to scientific opportunities. And that's really what IMAX is all about. So it's about getting people all over the world to contribute patients to get access to scientific investigations and publications based on analysis of multi-institutional data. An opportunity that they might not have in their own institution because they just don't have enough numbers, or maybe they don't quite have the expertise to do those kinds of analyses. So we put forth this proposal, as I said, in 2012. This database is sponsored entirely by ISHLT. This is a 3-year contract between we at UAB and ISHLT to see if we can get this thing running. And I emphasize there are no participation fees financially for hospitals who are involved. So this is truly an international registry to follow patients receiving durable devices. There are high standards, so if you're going to participate, you have to put in all of your patients, and we have ways of verifying the data and checking on it, just like we do in the United States. And again, the idea is promote outcomes research. We are going to be tracking a subset of the information that we collect in INTERMACS, but in fact, this information constitutes about 98% of the publications that come out of INTERMACS, so we have tried to simplify it just a little bit to increase the ease of participation, but we will be looking at pre-implant, discharge, and then follow-up, so that there will be routine follow-up information on major events that you can see here, and then on certain important adverse events related to outcomes after mechanical support. So any medical hospital outside the United States that has an active interest in devices is invited to participate. You do have to have serious participants in the device world. And then, of course, you have to be committed to transporting data. This is, importantly, data sharing. We are not taking ownership of anybody's data. This is your data. but you would be sharing it with us exactly as occurs in transplantation for the ISHLT. The benefits are that we would provide statistical summaries to the individual hospitals, which could be benchmarks for your comparing against international experiences, performance standards, perhaps help determine the resources that would be needed to meet performance standards, participate in device research, and potentially financial planning. And to the greater good for the overall MCS community, I have no doubt that this could result in improved outcomes by not only looking at new techniques and devices, but developing international standards for MCS therapy. It could facilitate the introduction of new devices. Industry is actually very much supportive of this database so that they would have more secure control study groups if they were introducing new devices in various countries. As I've said, scientific publications, and then very importantly, quality initiatives. It's of interest that INTERMACS now has an important part of our activities is quality assurance in the United States. It's not purely just scientific. So this is a list of another number of countries that have at least expressed interest and contacted us for enrollment over the past year. 50 individual hospitals, not including the 130 in the United States, are either early or actively in the enrollment process. Japan has promised that they will enroll. They're working their way through the process. I'm happy to say the UK has committed, and they are now going through the enrollment process. And of course, the US is enrolled. And these are some indications of the hospitals thus far that have worked through the IRB in regulatory approval process in their own countries and are beginning to enroll patients. So, I don't know, at least we're getting some more global representation than in just North America. So I'm mildly optimistic that we can have an impact perhaps on the knowledge base of mechanical support in these areas as well as North America. So there is a formal way to communicate and get opportunity to get access to more information if any of you wish, which I would be happy to facilitate. And so each week we seem to get one or more new inquiries about enrolling. So perhaps within the next 5 years we'll have a large contingency of non-US centers that are contributing data. Thank you very much.